There are now over 1,000 papers written about sonography of the cervix, and this is a very hot topic in the literature. While 15 years ago, when I began to study cervical sonography, we were kind of the pioneers in this field. Now pretty much every unit in the US and abroad is doing transvaginal ultrasound of the cervix, which can be done many different ways, as you can see from this 4D real-time display. Again, I want to thank everybody at Thomas Jefferson University, especially in the Division of Maternal Fetal Medicine, for their support. As the data that I will show you, it's really part of a team effort from everybody back in Philadelphia. The outline of the talk will be a review of the techniques, as we are in a sonography course, but I will also emphasize the clinical use of this sonographic procedure, especially as it relates to preterm birth, its prediction and prevention, and then symptomatic women with preterm labor and PPROM, and I will also explore some use of cervical sonography at term. First of all, I'm going to make sure you all understand that when we talk about cervical sonography, we do not talk about transabdominal sonography, but we talk about transvaginal sonography. When we first started looking at the cervix, we use transabdominal ultrasound, but there are many shortcomings to this procedure, as you can see in the slides. My point is that no clinical decision should be based on transabdominal ultrasound alone. We should not use transabdominal ultrasound, probably even for screening, because many times we miss a cervix that is otherwise shortened or open by transvaginal ultrasound. So please, if you really want to screen for preterm birth with cervical ultrasound, don't use transabdominal. Translabial could be used, but unfortunately also has shortcomings, especially the fact that the external os, as you can see in the slides, is difficult to see, and it's more difficult to obtain an adequate image than the standard, which is transvaginal ultrasound. The technique of transvaginal ultrasound, the way I like to, the acronym is TVU. You can also use TVUS, which is transurovaginal ultrasound, TYUS, sorry. Again, it's been around for a while, and it's really revolutionized OB/GYN in general. As you can see in this slide, the bladder needs to be empty. The procedure is safe, comfortable, and well accepted by patients, and it's really easier than even translabial. So that since you have the probe so close to the cervix and you get the best image, the technique of transvaginal ultrasound is the gold standard. The technique is very important, and I want to review it in detail. Again, once again, before you take the patient into the room, you make sure that she empties her bladder. Use a condom-covered probe. We usually let the patient insert such a probe. And as you can see, the probe goes into anterior fornix of the cervix, and then you obtain a view of the all length of the endocervical canal. As you can see in this picture, as I am pointing, here is the internal os, here's their external os. You want to make sure you don't put too much pressure on the cervix. You enlarge the image as much as you can, at least 2/3 of the screen, if not more. And then you obtain multiple measurements. In the literature, it is said that you should obtain at least 3. Use the shortest best measurement that gets a view of the whole cervix, and then repeat those 3 measurements after you apply transfundal pressure for a few seconds. The total exam should last at least 5 minutes, because over such time you may detect not only changes after pressure, but also spontaneous changes. You want to make sure you standardize this technique and you do it the same all the time, that the anterior lip of the cervix is similar to the posterior lip of the cervix, that you see the whole endocervical canal, and that, again, there's no increased echogenicity. That is the technique. But why do we do transvaginal ultrasound? We do transvaginal ultrasound mostly at this point to predict preterm birth, whose incidence has been increasing tremendously, at least 30% in the last 20-25 years, and is now 12.7% in the US, which is over 500,000, over 500,000 births every year in the US are delivered before 37 weeks, and about 2% below 32 weeks. Transvaginal ultrasound of cervix has been shown to be really the most predictive test for preterm birth because the cervix, when it's going to open, begins to open at the internal os, finding that you cannot detect on manual exam. So we're going to review how well transvaginal ultrasound predicts preterm birth, looking at a comparison to manual exam, what you're going to measure, what is normal or abnormal, when to do it, what kind of clinical scenarios you're going to look at, and its utility. We do know from a study now done 12 years ago and replicated multiple times, then as you can see on the left part of the slide, cervical length by manual exam does predict preterm delivery, but cervical length measured in the same patients by transvaginal ultrasound has a much higher probability of detecting preterm delivery, a much higher area under the curve, and a much more significant p-value. You can take multiple measurements on transvaginal ultrasound, as again you can see in the slide, but cervical length or the closed part of the cervix, even if there is a little bit of opening up at the internal os, is what you want to measure. So the distance from the external os to the end of the closed part of the endocervical mucosa. As you can see here, the measurement in a normal long cervix is 1 inch to 2. When you're measuring a short cervix, again, you don't want to measure the whole length of the cervix, but you want to measure the length of the cervix that is staying closed, as we used to call it, the functional length. You can also mention in a report the opening ear funneling. We most reported as B over A plus B in terms of measurements in the slides, but that's really doesn't add much to the prediction. And here you can see it in the slides, funneling in terms of degree of funneling is related to a higher and higher incidence of preterm birth. But it's so subjective, as you can see in this slide, really hard to tell what the internal os was, that really cervical length is the accepted gold standard. We do know, though, that the few patients that have a normal cervical length but have significant funneling have increased an increased risk of preterm birth. Sometimes you see cervixes that are closed, and what are you going to measure? You could measure os to os, so to speak, but usually when the distance between the cervix and this imaginary direct line is more than 5 millimeters, we prefer to take 2 measurements and add those 2 measurements together. Again, when you have a curved cervix, that usually means that it's a long cervix. If you have a short cervix, it's almost always going to be straight. And so the fact that you see a curved cervix shouldn't make you worry too much, but it's actually a reassuring finding in terms of preterm birth. There are several pitfalls to transvaginal ultrasound. It's not a perfect technique. Again, you want to make sure that you avoid some of these technical and anatomic pitfalls. As you can see in these old slides, we used to not be too attentive to empty the bladder, and it's very important to empty the bladder. These bladders are too full and may mask some funneling, as probably it's happening on this case on the right of the slide. So again, you want to make sure that the bladder is completely empty, and if there is any fluid in the bladder, it's a little bit of a slit there, and the cervix appears to be in its natural state. You don't want to put too much pressure on the probe, and you can see that by the fact that here there is the echogenicity of the anterior lip. It's excessive. This anterior lip is too white, so to speak, and it's also much thinner than the non-compressed posterior lip of the cervix. You also want to make sure you see the whole cervix, and you place the calipers in a good positions. I really don't know in review from this case many years ago, again over a decade ago, what the sonographer was measuring. You want to take the whole cervix and make sure you know where the external and internal os are and where the new internal os after funneling is. Again, it's very difficult to place calipers when you have funneling, and that's why measuring this remaining functional closed cervix here is most